Your passcode has been confirmed. If you need technical assistance during your call, please press star followed by 0. After the tone, please state your name. Thank you. There are 49 parties in conference, including you.
We'll be waiting until after the presentation to open up the floor for questions. And since we can't actually to make a comment, I'm going to ask people to electronically raise your hand if you wish to speak. So if you would like to raise your hand, you click on the Q&A tab on the menu bar, and then in the Q&A window, click on the hand icon in the upper right-hand corner. This is going to display your name to us here at the CDC, and we'll be able to call on the participants as their names are displayed at the end of the presentation. Once we call your name, I'd like you to please state your affiliation before asking a question or providing a comment. And just as a reminder, you can raise your hand during the presentation, but we're going to wait until the discussion period for those comments. I also want to let everyone know that this session is being recorded. So with that being said, I'd like to introduce today's presenter, Dr. Ifeyinwa. She obtained her medical degree in 1994 from the University of Nigeria School of Medicine, Sciences, and Dentistry. She has been avidly involved in sickle cell disease clinical practice for over 20 years. In Nigeria, she provided public health education about sickle cell and vaccinations to those affected in rural Nigeria. She has a master's degree in public health from Johns Hopkins University, did a pediatric residency at the University of Medicine and Dentistry in New Jersey, and received her hematology oncology fellowship from Columbia University Presbyterian Hospital in New York. Dr. Ify joined the faculty at Emory University in 2005. She was the medical director for the CHOA Sickle Cell Disease Program from 2007 to 2010. And that program provides comprehensive care to over 500 patients with sickle cell. Her research interest is in nutritional determinants of sickle cell disease severity and sickle chronic pain syndrome. She is currently the PI on 2 investigator-initiated clinical trials looking at the role of vitamin D, sickle cell disease chronic pain, and the impact of micronutrient status on immune function in sickle cell disease. She is also the site investigator for a multi-center study of L-glutamine for sickle cell pain. Dr. Ify is the medical director of the Pediatric Adolescent Teen Transition Program that graduates 40 adolescents with sickle cell disease yearly, the medical editor for the Atlanta Sickle Cell Disease Consortium quarterly newspaper, and the director of the Children's Hospital of Atlanta Sickle Cell Awareness Planning Committee for the past 4 years. She is board certified in pediatrics and board eligible in pediatric hematology oncology subspecialty. Dr. Ify's research interests include vitamin D deficiency causes and correlates in sickle cell disease, clinical correlates of micronutrient deficiencies in sickle cell chronic pain and bone disease, complementary and alternative therapies in sickle cell disease, and health literacy and effect on clinical outcomes in sickle cell disease and sickle cell transition to adult care. So I am now going to turn it over to our speaker today. Thank you.
Thank you. Good afternoon, everybody, and thanks for inviting me to CDC and the Division of Blood Disorders. I appreciate this opportunity. The title of my talk today is going to be on vitamin deficiencies in sickle cell disease with a broad focus on vitamin D deficiency, but I'll touch on the macro and micro deficiencies that we know is common in this patient population. Next slide. Next slide. So as a pediatric hematologist, my goal in life is to ensure that my patients grow up to be healthy and hearty, and they can fill the shoes of those that have gone before them, probably better than those of us who are ahead of them. And with that in mind, what the objective of this talk are kind of threefold.
She just started. She's put her first slide on. That's it.
Can everyone please check and put their phones on mute? Thank you.
So the objective of this talk is to review the pathophysiology of sickle cell disease, mainly as it regards to growth and development and nutritional status, look at the dietary requirements for energy, macronutrients, and and micronutrients of sickle cell disease, and also look at vitamin D deficiency specifically. And then I hope we have enough time to talk about future research and comprehensive collaborations in the future. Next slide. So the pathophysiology of sickle cell disease all ends in chronic organ damage over time. Because of that single amino acid mutation, we have red blood cells that do not, that can change their shape and become more rigid as they flow through the vasculature and lead to inflammation, tissue hypoxia, and eventually ischemia of different organs. In the bone, it causes acute pain that leads to chronic pain. It can cause acute chest syndrome. It can cause bone problems, spleen problems, and strokes. Next slide. A normal blood smear looks like this, and I know that my audience is very diverse. I'm trying to make this not too technical, but also not too lay, to capture a broad variety of people in the audience. I'm a very pictorial thinker, so I think in pictures and I think in color. When I think about sickle cell disease, I need to understand how is it different from the body of a non-sickle cell person. This is a sickle cell smear. Next slide. And this is the sickle cell smear. Basically, you see there's a decreased number of red blood cells with an abnormal shape, and also a higher number of white blood cells and more platelets. And this is what causes all the issues with sickle cell disease. If you think of your blood as what carries nutrients and oxygen to different parts of your body, if you have a smear like this, there's got to be something that doesn't go right in your development and your growth. Next slide. And so over time, with sickle cell disease, when you have low oxygen tension, the cells tend to change shape and sickle, and they go from being a round biconcave disc to a deformed banana-shaped, sickle-shaped cell. And next slide. This is what happens if you have this occlusion happening in the hands of a child. You have swelling, you have edema, you have pain. And basically, this is end organ damage to the hands of a child with sickle cell disease. Next slide. The triggers of sickling include low oxygen tension from either sleep apnea, asthma, congestion. There's fever, infection can trigger hypoxia, dehydration. We're learning a lot more about physical and emotional stress that triggers sickle cell sickle, and extremes of weather conditions. So we talked about everything ends up in end organ damage. So in the lungs, you have acute chest syndrome. We see the x-rays over there. In the hands, for a young child, you see dactylitis that affects the bones and the tissues of the hand. Ischemia. In the head, you see strokes. In the spine, you get compression fractures where the perfusion of the spine is compromised, and because of pressure, the bones in your spine tend to crumble. In the extremities, you can get leg ulcers and osteomyelitis or bone infections because you have poor perfusion and then infection of your skin and the subcutaneous tissue as well as the bone body. Next slide. I also want to talk specifically about avascular necrosis. This is where you have damage to the bones in a sickle cell patient, particularly the head of the femur or the humerus, but it can happen in any bone whatsoever. And this is important because almost every sickle cell patient will end up with avascular necrosis over the course of their life. The prevalence is very, very high, and the treatments are very unacceptably, they're not positive. They're unacceptably, there's a lack of positive outcome in treating avascular necrosis. Even if you get your joint replaced, they don't last very long, and that's because you're putting a new joint in a damaged bone that has the potential to continue to be damaged over time because of sickle cell disease. Because of that, they have a high morbidity and they can have a high mortality. There's a lot of pain and utilization of health care. And the risk factors include high hemoglobin, low hemoglobin F. The last point is the most important point, and that's what's the kicker for me, that despite adequate treatment that we have for sickle disease, including the transfusions and hydroxyurea, we have not impacted the risk of AVN in sickle cell patients. So they still continue to have bone problems over time, despite these very good treatment modalities. Next slide. And again, this is putting it in a pictorial perspective. You have avascular necrosis of the head of the femur. Next slide. And you have the spine compression fractures that also affect the bones in sickle cell disease. Next slide. So what are the nutritional needs in sickle cell disease, and how are they different from a patient who doesn't have sickle cell disease or an individual without sickle cell disease? We know from seeing our patients in the clinic and from the community that they have poor growth and poor nutritional status. They have delayed bone and sexual maturation, and this is very, very common. It's almost like accepted as the norm. We believe it's because they have a higher red cell turnover. The cells with sickle cell disease, the red cells live for only 14 days compared to 120 days in a non-sickle cell person. And because of that, you have an increased metabolic demand for every nutrient, be it protein, be it carbohydrates, be it fat, be it vitamins, minerals, etc. Because of sickle cell disease, there is an increase in inflammation and endothelial damage that causes oxidative stress, and so the body is unable to mop up the oxidative molecules that are produced from hemolysis, and this can actually, in addition to hemolysis, worsen the clinical picture of sickle cell disease. We tend to have our patients fall into the lower socioeconomic strata, partly because of their disease and the increased need for care and their lack of keeping down a job. There may be issues with food insecurity where they cannot have access to adequate diet. And also cravings such as pica, which is very common in people with anemia, tends to be very common in sickle cell disease also, and that can complicate your poor nutritional status. Are there genetic factors separate from your hemoglobin mutation that puts you at an increased risk of a poor nutritional status in sickle cell disease? We're yet to figure that out, but I think there may be some components as well. Next slide. So in terms of macronutrient needs, which is basically your protein energy needs for sickle cell disease, we have documented research that has shown that there is a hypermetabolic state in sickle cell disease with a high protein turnover, and they need more energy to survive compared to non-sickle cell peers. There is poor growth and development, both in the U.S., which is a first world country, and in third world countries around the world. So having a higher gross domestic product has improved this somewhat, but hasn't eliminated the need for attention to growth and development in sickle cell patients in the first world. There's only one study to date that has looked at calorie supplementation in sickle cell disease, and that was a study by Heyman in 1985 that had 5 children who were given additional protein and calories to supplement their diet, and it showed that they had improved growth and development and clinical status over time. However, they used different supplementations for the 5 different patients, and it wasn't a standardized or a prospective study. Now, anecdotally, in my clinic, I'm sure other clinicians in the audience will know that when you have a child who's not doing well with sickle cell disease and you feed them a high-protein diet or a high-calorie diet, they tend to do better with recovery, with dealing with their pain, and with handling sickle cell disease overall. However, we haven't done a lot of prospective randomized trials to determine exactly what diet is the right diet and what combination of nutrition is the right nutrition combination for sickle cell patients. Next. Dr. Hibbert from Morehouse School of Medicine has done a study looking at the differences between sickle cell SS patients and people with AA in terms of their energy turnover, and have confirmed that the sickle cell patients tend to make more hemoglobin per gram of body weight, synthesize more protein, but also break down more protein. So they have, as I had mentioned before, an increased metabolic turnover. And she developed a novel nutritional supplement in the form of a cookie that had extra protein and fat as a way of supplementing these patients in terms of their diet. And that study is ongoing. Hopefully we'll get the results of what that showed in the next several months. Busen et al. Had looked at body mass and bone mass in sickle cell children compared to controls, and confirmed that even though they had the same, there was no difference in lean body mass in sickle cell patients versus controls, there was a significant difference between the mass per height and also fat mass per height, as well as the bone mineral area and bone mineral content in sickle cell patients compared to controls. Next slide. And when you graph the growth and development of a sickle cell patient compared to a control patient, they tend to fall within the lower percentiles of growth. This shows boys and girls whole body bone mineral content in terms of grams per age. And you notice that they fall within the 3rd to the 75th percentile, but some of them fall below the 3rd percentile. Now, historically, we have assumed that sickle cell children should follow a separate growth curve. When you look at the sickle cell growth curve, it tends to be percentiles lower than that general pediatric population. I think that there's a push right now to try to look at every sickle cell patient as having the potential to develop within the normal range for the average population, and begin to address what is the reason for that deficit and what is the reason for that change in percentile point. Why don't we have anybody in the 50th to 75th percentile, but we have them more in the less than 3rd percentile? Next slide. Al-Sakradi in 2008 had reviewed all the micro and macronutrient studies in sickle cell disease, and about 46 that he looked at to see what is the state-of-the-art knowledge that we had about nutritional issues in sickle cell patients. Most of these studies were observational with very wide variability in terms of reference range and sample selection. But overall, there was a pattern of growth failure that was confirmed in sickle cell patients from all geographic areas. I had touched on this a little bit before. And there was good evidence linking growth failure to endocrine dysfunction, metabolic derangement, and nutrient deficiencies in terms of vitamin, like say vitamin A, vitamin D, vitamin E. Next slide. So we have all this, knowledge that there is a problem with regards to nutrition and sickle cell disease. The issue is, what have we done with it, and what exactly does that mean, and how does that translate to clinical care? If you look at the folic acid story, in 1961, there was a sentinel paper in New England Journal of Medicine that talked about folic acid and sickle cell disease, and we agreed that the sickle cell kids should always be given folic acid to help their red blood cell survival and decrease the chance of metabolic anemia, and that's kind of standard of care across the board. There are papers that date back to the 80s that talk about, B2 deficiency in sickle cell disease, vitamin A, vitamin B6, vitamin D. But despite all of this, we do not have standard of care guidelines for vitamin supplementation to correct these issues that we know exist in sickle cell patients in everyday comprehensive sickle cell care. The other thing that complicates the situation is that you cannot just treat one vitamin deficiency and think that you're going to solve the whole problem. If you have folic acid deficiency and you have B2 deficiency, well, are your red cells not surviving because of folic acid or because of the vitamin B2 or because of both of them in combination? So they cannot be looked at individually. It has to be looked at in total. Next slide. And why is this important? Why do we even care about looking at nutrition and growth and vitamin supplementation in sickle cell disease? Well, we cannot separate growth and development from long-term morbidity and mortality and disability. Sickle cell disease is associated with a lot of pain, and that it progresses to chronic pain. With a high mortality rate, the more pain you have. If there's a way to understand how your development affects your pain status, could that decrease your morbidity and your mortality? Could we affect your loss of days of work and school? Can we affect your infection rate? Can we affect your issues with depression and learning? I could have started because in pediatrics, I was told as a resident that iron deficiency anemia problem in pediatric patients under the age of 5. But we do not look for iron deficient anemia in sickle cell patients. It's not our standard of practice. We assume that they have iron overload, and that's what we need to focus on. But these people are children first and have sickle cell disease second. So I think we need to begin to take a step back and look at them as individuals who can have the same deficiencies as anybody else in the general population on top of having sickle cell disease, which may exacerbate the entire picture. There is a high healthcare cost to sickle cell disease, morbidity, and disability. Upwards of $1 billion a year goes into taking care of patients with sickle cell disease and their complications. So there is an incentive to try to decrease this cost by improving care on the other end. Next slide. I'm going to segue into my specific interest in vitamin D deficiency in sickle cell disease. So vitamin D is a hormone that is synthesized in your skin, and its whole purpose is to regulate your calcium and phosphorus metabolism, okay? The flux of calcium into the bone and the efflux of calcium out of the bone. About 90% of your vitamin D is made in your skin. The rest is obtained in your diet. Breast milk only has about 10% of the quantity of vitamin D in fortified cow's milk, so if you're exclusively breastfed, you will not be able to maintain your vitamin D status. If you have low vitamin D levels, you have poor bone mineralization, and this can contribute to osteoporosis, muscle weakness, and increased risk of fractures. And this is known across the board for the general population. Now, vitamin D is absorbed in the skin and then activated in the kidneys and ends up as an active 1,25-hydroxyvitamin D is what actually is the active hormone. The different actions of vitamin D include its effects on the bone, which I talked about, but it also enhances your immune function and has anti-tumor activity. There's a lot of data now that talks about vitamin D with regard to tuberculosis treatment and prostate cancer and breast cancer and decreasing your risk of cancer recurrence. In your kidneys, it enhances calcium reabsorption. In your pancreas, it stimulates insulin production. And vitamin D has been shown to modulate your risk of diabetes over time. So not just with your bone development, your other endocrine and immune status may be impacted by your vitamin D status. All right, so the multi-system complications of vitamin D deficiency, people think of vitamin D and think about rickets, which is a picture on the slide in the upper right-hand corner from where I'm sitting. But it has also other effects. So what do we think about with vitamin D for sickle cell disease? Well, could it cause muscle weakness and pain? could it cause osteoporosis? And what does that look like in a sickle cell patient? We don't know. So you can skip. Next slide. Next slide. So that's where the muscle weakness comes in, the asthma and wheezing. Could it affect your lungs? Could it affect your acute chest risk? Next. Could it affect your ability to fight infection and fight off influenza virus? Could it affect your risk of depression? Next slide. In the United States of America, about half of African Americans are vitamin D deficient. And this is a really, I guess, scary epidemiological fact. You would think that with the fortification of milk that we have in the first world countries, we shouldn't be having this much vitamin D deficiency. However, it is quite prevalent, not just in African Americans, but all across all populations in the U.S. Risk factors for vitamin D deficiency include lactose intolerance, which is very common in African Americans, poor sun exposure. We live in a very industrialized environment where we go from our car to the work, back to the car, your skin pigmentation and your metabolic state. And these are all risk factors that are a little bit more exacerbated or more true in sickle cell individuals. Next slide. Now, what do we know about sickle cell disease and vitamin D deficiency? There are about 15 articles, and I think every year a couple of more articles come out confirming that vitamin D status is low in sickle cell disease, and that's the take-home message from the next two slides. Basically, if you have sickle cell disease, you're more likely going to be African American, and you're going to have low vitamin D levels. And the rates are higher in sickle cell disease compared to the average African American population. That's the issue that we're trying to understand. Why is it that if you look at all African Americans, you have a 42% prevalence rate, but among people with sickle cell disease, the rates range from 65 to 100. Is there something about sickle cell disease that makes you more at risk of vitamin D deficiency, or is it too true and unrelated? Next slide. More articles. Next slide. There's been a lot of data that has linked vitamin D to decreased risk of fractures, irreversible fractures, a higher risk of cardiac death if you have deficiency, and also the rates of type 1 diabetes. I think this is a very interesting study from Finland where they gave little babies vitamin D, and over the course of their life, their risk of type 1 diabetes dropped by 8%. That's pretty profound. And also the cardiovascular study, the Framingham study, has shown a low risk of cardiovascular mortality with vitamin D supplementation. Next slide. Now, there are several studies that have talked about vitamin D and pain, and they go either way. Some of them talk about vitamin D can improve your pain. Some of them talk about no difference in vitamin D with pain. They're all very different in terms of how they were designed and how much vitamin D they administered. The ones I have up here are the ones that gave high-dose vitamin D, so they gave up to 600,000 units of vitamin D over 2 to 3 months and documented improved pain in a proportion of patients with profound vitamin D deficiency. Next slide. Next slide. There was one study that had looked at vitamin D in sickle cell patients, and this study by Adewoye from Boston had given about 800 units of vitamin D over a course of a year, and he looked at your vitamin D level, did they improve? He looked at your bone turnover, did they improve, and also your bone mineral density. He found an improvement in your vitamin D levels and your bone mineral density, but no change in your bone turnover, which is kind of interesting. However, he did not look at any clinical correlates of vitamin D deficiency or treatment of vitamin D in that patient population. So we don't know if their pain got better, did they have less infection, did they have less acute chest? We just don't know. And so there's a case report that's coming out in JPHO this year that looks at a 16-year-old sickle cell patient with poor growth, avascular necrosis, delayed puberty, all issues that are very common to sickle cell disease, who had chronic pain, unresponsive to your standard therapy, and she also had osteoporosis. And she was given vitamin D, 2 high-dose courses, because she was profoundly deficient. And by the 3rd month, she was completely off of all her pain medication, off of her hydroxyurea, and she has not had an admission or a pain episode in 3 years. Now, this is not the gold standard for treating pain. This is one case report that raises the question, is there a role for vitamin D in treating sickle cell chronic pain and or acute pain, for that matter? Next slide. So I looked at a group of our patients at Children's Healthcare of Atlanta, about 53 patients, and I wanted to understand what is the epidemiology of their vitamin D deficiency. What is the spread? Do we have kids who are normal and kids who are not normal, and how low are they? And basically what I found was that none of my patients had normal vitamin D levels. most of them had levels below 10 nanograms per ml, which is profoundly deficient, but there were some who were in the in-between zone. And we also found, next slide, that the level of vitamin D deficiency was very well correlated with the degree of chronic pain you had, and, next slide, the likelihood of you having avascular necrosis or a compression spine fracture. Okay? And I thought that was very interesting. So it's not just your low, but how low is low and how low is significant to cause clinical complications of sickle cell disease. Next slide. So we embarked on a prospective study looking at vitamin D to improve sickle cell chronic pain, with the hypothesis being that if you take high-dose vitamin D, your chronic pain will improve, and also your bone health will improve. Next slide. This was a randomized, double-blind, placebo-controlled trial. The age of enrollment was 7 years to 21 years. And we defined chronic pain as you having pain on more than 50% of the days every month. And we used a pain diary and also double-check with their medical records and hospital reports. We enrolled sickle cell SS and S-related thalassemia only. Now, it was very interesting that when we first started the study, we had wanted to talk about chronic pain based on what the physician thought chronic pain was. How often have you been to the hospital? How many times have you given prescription for pain medication? However, as we proceeded with the study, we found out that a lot of patients do not report pain when they come to see us in the clinic. When you give them a diary, they have pain every day, but when they come to clinic, they're fine. And so we had to revise our definition of what chronic pain really is. I think that's very important when you're looking at sickle cell disease and any kind of intervention you're going to do. You have to understand it based on what is reality for the patient as opposed to what we think is our reality as an investigator. We just finished, we just close to accrual for this study. We did not reach our enrollment target. We were planning on getting 30 in each group, but we got 27 in the non-pain and 11 in the pain group. Now, this is not because we did not have 30 patients with pain. It was because it was very difficult for somebody with chronic pain to engage in a 7-month study with any degree of reliability without a lot of challenges. And we're looking to see what the data is going to show over time. We're starting the analysis this month. But I'm interested in understanding a couple of things. One, did it make a difference? And if it did, what does that mean? We're looking at things like vitamin D receptor polymorphism, cytokine levels. We have data on depression. We have data on hospital usage, narcotic use. So it's going to be a lot of data that comes out of this study that will be informative in designing something further, something larger going forward. Next slide. We did do an interim analysis after the first 17 subjects were enrolled to look and see, do these patients respond to high-dose vitamin D? And if they do, will that be sustained over the course of the study? So we looked at the first 17 patients, 6 with chronic pain and 11 with non-chronic pain with a mean age of 14.2. And they had similar baseline vitamin D levels, which was 17.9, which was interesting because this tells you that not everybody with chronic pain had profoundly low vitamin D levels. And over time, the people who had the drug, their vitamin D levels rose to 52.3 nanograms per DL, but over time it promptly dropped down to 24. We don't have the week 24 data yet, but I'm wondering if they're going to drop back to their baseline by the end of 6 months. And they were all given a daily vitamin D supplement based on the required daily amounts of vitamin D and calcium to take every day. And so a couple of things we point out here. One, they need more than the RDA to keep their vitamin D level steady. 2, were they compliant with their medication? And so we're going to have to tease that out when the data gets analyzed over time. So basically, from this study, we could surmise that vitamin D is very common in sickle cell, just like it is around the world. It can be associated with chronic pain and AVN. And it prompts screening for vitamin D deficiency in all sickle cell patients. This is such a prevalent biochemical marker that we need to look for it and do something about it. But the question is, if we treat it, how long do we treat, how much do we give, and what do we expect to find as an output in terms of their response to therapy? So there is a need for longitudinal randomized studies to better understand what this means in sickle cell patients, and also look at other non-bone markers. So what about the lung, the immune function, and the CNS? Next slide. Okay, so going back to the overall picture, nutritional status, multiple micronutrient deficiencies, protein, energy, malnutrition, and sickle cell disease. If we believe that all children are created equal, we should not accept growth abnormalities in sickle cell disease as the status quo. This should not be normal to have a child who's an FTT or fails to thrive. We should look for a reason why they're not growing and begin to supplement them with what they need to enhance their growth and development so they can achieve optimal adult outcomes. we have to begin to understand that micronutrient deficiency in sickle cell disease is very important, and we need to do something about it. And also, it's complicated. It's not just one vitamin. It's multiple different nutrients that they're deficient in. And there's need for guidelines for supplementation in sickle cell disease. We have no standardized guidelines. Except for folic acid, there is really nothing out there for pediatric sickle cell disease that says, give, or even adult sickle cell disease, give this in this amount over this amount of time in this interval. Is it time for a sickle cell multivitamin? We went for a meeting at the NIH last year, and we really kind of talked back and forth about what is the right approach for sickle cell disease. When they have multiple different nutrients are deficient, should we give one vitamin, or should we have a standardized vitamin that is made for sickle cell disease, or should we give them, a mishmash of different already approved products? Would that be sufficient? And then lastly, the research into genetic disease-specific risk factors that predispose to these nutritional deficits is very important in sickle cell disease, and we need to have quantitative endpoints. Next slide. There is a lot of research about the presence of these issues in sickle cell disease in terms of nutrition. It's very easy to give calories to a patient. I mean, this is America. Food is cheap, relatively cheap, I should say. And so it shouldn't be a problem to feed our kids. Or we should find why are we not feeding our kids sufficiently? Second thing is vitamins are also cheap overall, and they're widely available. So the next step is, what are we doing about it? Why are we not giving our patients the supplement that they need? Why don't we understand or appreciate these deficiencies in our patients? Next slide. Next slide. If these kids were in America, they would raise a lot of horror and social anxiety. And I want to challenge people that this is how we need to think about sickle cell disease compared to non-sickle cell individuals. If they have such profound deficiencies, we need to begin to address them prospectively and proactively, as opposed to waiting for them to grow up, become adults who have multiple complications. Next slide. With the vision being that the kids we saw in the picture before should look like this as they get older. Thank you very much, and I'm ready for questions.
Thank you so much. We're now going to open the lines for questions. So please remember to keep your phones on mute when not speaking. In fact, if everybody on the phone could just double check and make sure their phone's on mute, that would be great. So if you have a question, raise your hand electronically, and your names are going to be called in the order received. And we only have this line scheduled for an hour, but that's about 20 minutes, so we should have plenty of time. Let's see. We have a question from Sean. Given that most individuals with sickle cell in the U.S. are Black, and there's a greater likelihood for Black persons, regardless of SES, to live in so-called food deserts, this presents a unique opportunity to examine sickle cell disease in a broader public health context. Number one, are there any such studies making use of such data? And number two, what would be the ideal outcomes to examine?
Very good question.
That's a long question. And so I'm not aware of any studies that have looked at sickle cell disease in terms of food deserts in a public health perspective. What would be the right source of data? You're never going to get everybody, because if you look at pregnant women with the WIC program, you get a small snippet of pregnant women with sickle cell disease. But that's a small population compared to the larger number of people affected by sickle cell disease. If you look at children on WIC or public assistance, that may be one way to pick up the pediatric group. But the adults may not be on either of these programs, and you're missing a huge chunk of our patient population. So I'm open to what people think. What other suggestions are out there? How can we look at this in terms of a larger public health prevalence issue in the U.S.?
I think that question is open for discussion, or if anybody has another question they would like to ask, if you can identify yourself. Do we have any other questions from anyone on the phone today?
I have a corollary to that question. This is Althea Grant, CDC. In the earlier slides, you showed the growth curves and where sickle cell patients fall with respect to the general population. My first question was that a general population, or was that compared to other African Americans? And also, one way one might look at this question is the effect of sickle cell disease might be in these food deserts. Look at us doing family-based studies, so comparing children growing up in a similar environment, similar genetic background, and the effect of sickle cell on one sibling versus another.
So this slide was actually bone mineral content, and it was looking at the general pediatric population, but I don't think it was specifically in Black. I think it was general population, like everybody, all comers. But if you look at the growth, the height and weight charts, they look the same. They look very similar. And so the other part of the question was looking at patients growing up in the same environment. Like if you look at a sickle cell child and their sibling, there tends to be a difference. Within the African American and the Caucasian, same age and gender, there is a difference as well. So there is, that drop off based on, ethnic factors and also based on disease factors. But even if we say that sickle cell patients should be the same weight and height as their gender matched, environmentally matched, ethnic matched controls, they still are below.
Okay.
They're still at a disadvantage, yeah.
Okay, it looks like we have another question from Elizabeth. And her question is, would you consider adding vitamin deficiency evaluations to an annual comprehensive evaluation?
So the question is, will I consider an annual vitamin deficiency evaluation? The answer is yes, and the answer is no. The answer is yes. I think that we need to document these deficiencies. The answer is no because I don't know about it. I don't know what I should do. If I notice that they have low everything, I'm going to give them. Am I going to give them the standard dosing for a general pediatric patient? Am I going to give them high dose, or am I going to give them a modification of the dose that I make up out of my head? What I do now with my practice, I tell every family, put your child on a multivitamin over the counter. Right? That's what I do for everybody. Until we have more data as to how to best treat these deficiencies in sickle cell patients. I think just randomly doing, it's going to be very expensive to do all these levels on everybody, and we may have issues with insurance companies not wanting to pay for it and hospitals losing money, so that may be a challenge there. If we know they have a deficiency, so that most of them have a deficiency, put them on a multivitamin so we can come up with more data as to what is the right type of multivitamin that we need to give them. Now, we do look at growth and development, height and weight, and if they drop off their curve, for macronutrient deficiencies, and we supplement them with either high-protein shakes or NG2 feeding. That, I believe, should be standard of care. With regards to the multiple vitamins, it's going to be hard to test for everything out there and try to replace them one by one without a command.
Thank you so much. Are there any further questions from the audience today?
As a presenter, can I ask a question?
Yes, of course.
Okay. Can I hear from the individual with sickle cell disease or people from the community who are in the audience as to what your thoughts are with regards to nutrition and vitamins and deficiencies in sickle cell disease? What do you guys see? What is pertinent to you? Because I'm speaking from a physician point of view, and I'm speaking from, my research interest, and, I need to know what the community think about when they think about nutrition and diet and development of sickle cell.
My name is Kim Lee, and I'm on the line via phone from the community-based perspective. And I'm a mother, and one of the challenging things that I find is dealing with the medical doctors at large. And one of the challenges are the format in which they use is a very standard format. And to a certain point, they're using the same standardized growth, and development charts that would be used with, a child who does not have this disease. And from 0 to 5, we were basically following the same protocol and procedure, not unless there's something alarming based on nutrition. And believe me, I spent many nights, sometimes weeks in the hospital, dealing with nutritionists, dealing with the hematologist, and it's the same format. And the big question is how, as a preventative measure, can a parent start this child on a path for an overall quality of health program? And there's nothing available. The nutritionists still use the same FDA food pyramid for every child, which does not match the needs of a sickle cell child. The pain treatment is pretty much the same, but they don't talk about nutrition at all. They don't focus on the quality of health overall. It's kind of just, stick this in front of you and then, see you the next time. So I find it very challenging in dealing, with the medical community and not waiting to the last minute to do something different. And I'm looking for you in particular to, continue the research to find diet and nutrition is to me, prevalent. It's almost mandatory that these people start off on that path.
Well, I hear what you're saying, and I want to encourage you that it's getting better. It is getting better. If I may speak for my physician colleagues, the reason why we haven't done much different is that we don't know what to do, or we haven't known what to do, okay? We haven't known what to do with regards to a child who doesn't grow, or a child who, is eating a lot but not gaining weight. I think right now there are a lot of research in sickle cell disease is focusing on non-medication interventions, so nutritional ways of improving health. There is a study out there that's looking at glutamine as a protein to improve sickle cell pain. But we're going to also look at weight and height and development, things like that, to kind of see what the outcomes are. So there are people who are interested in figuring this out and who are working on it actively right now, so it is going to change. Now, we do know that if you have a high metabolic rate, you need more calories proportionally to how high your metabolic rate is. And what we need to do when we talk to a nutritionist is to say, what, my child has sickle cell disease, and my nutritional requirements are 1.5 or 1.3 times higher than everybody else, and go from that standpoint. And there is data out there. I think the Hibbert study, if you look at that paper in better detail, they talked about what the proportional difference is between protein, carbohydrate, and fat. And sometimes dialoguing with your physician is helpful, saying, look, this is a paper that I just reviewed. This is what it says with regard to nutrition and growth. Can we begin to incorporate this into my child's care plan? I welcome, I think most physicians welcome the parents providing us with data that helps us decide that this is an okay thing to do. Because if you're worried about what to do and you don't want to do the wrong thing, I don't want to give everybody vitamin D and say this is going to make you better. What if that doesn't work? What if it makes you sicker? We're supposed to do no harm. So I think it has to be a dialogue, and it's going to happen over time. But there is more research going on to address that particular need. Even with the NIH, there's funding looking at alternative therapies for every disease, from cancer to sickle cell disease to epilepsy to heart disease. They're looking at dietary interventions for health. And so you're going to start seeing more and more of that coming down the pike in the future.
Well, I look forward to that being of a resource. That is good news to me and to the especially to the little ones who live it day in and day out. Another nutritional component of this is really caloric-based right now. It's not really into the metabolic panel, and I'm just wondering, are parents and families being educated that the metabolic panel of the children is very important? Without that, you really don't have a source point. So I'm just wondering how that can be incorporated in the dialogue.
So if you talk about the metabolic panel from the perspective of the kidney and the liver function, that is standard of care in most practices, and I think that will not be the question. If you're talking about a metabolic panel in terms of all your multiple vitamin levels and things like that, the issue is cost. The issue is who's going to pay for it. The issue is, will the insurance company approve doing that every year? It's a pretty expensive panel, and we don't have enough data to tell them this is what I'm going to do when I get all this information. And so once the data matures and we have a guideline, a plan, then I think it will be easier for them to say, okay, we're going to pay for this every year for this group of patients. I think that's going to take a little bit longer and more dialogue.
Okay, but can one actually ask for that metabolic panel as a, part of the overall care?
I'm not sure. I don't think there's any place that's doing it routinely at this point. Most of what you see are research studies.
Okay, I'm going to interrupt just because we have a few more questions on the line. So I'm going to go to the next one. This is from Hyacinth. She says, given that African Americans generally have a lower vitamin D level compared with Caucasians, how do we know when bone changes are being caused by the sickle cell disease itself or due to vitamin D deficiency?
And so the answer to that is that we don't know, which is why we're doing the research. We don't know, but we need to understand what does vitamin D deficiency do to a non-sickle cell person. It causes pain, it causes muscle weakness, it causes fractures. If you begin to see that in sickle cell disease and you're treating the sickle cell disease with everything that you know to do to treat sickle cell disease and it ain't working, then you need to begin to think about, okay, what else could be going on? So the case I presented was the 16-year-old girl. She was on transfusions. She was getting hydroxyurea. She was very compliant. She was on all her pain medications, taking her medicines every day. She was getting a psychology counseling. She was doing physical therapy. And her pain was not getting any better. It was getting worse. That was what prompted me to look at her vitamin D levels, and they were like less than 8, almost like 0. And she responded to vitamin D so well that I began to wonder, wow, how much of all this past 3 years was vitamin D deficiency more so than her sickle cell disease? I think you're always going to have to juggle. It can't be either or, it has to be both and. So you cannot say I'm going to give vitamin D treatment and not treat the sickle cell disease, or give sickle cell and not think about other causes. You have to do them both in tandem. But you're absolutely right. It's a big confounder in our patient population that we haven't looked at in the past.
Wonderful, thank you. So the next question is from Nora, and she asked if there is an ideal dose that should be given to patients with sickle cell. And I'm assuming that this is an ideal dose of vitamin D.
So the interesting thing is that there is no ideal dose. What the American Academy of Pediatrics came up with about 2 years ago, I think, was every child should take 800 units or 1,000 units of vitamin D every day. I've tried that in my patients. It's not enough. I've gone with the adult dosing for vitamin D deficiency, which is 50,000 units a week, and that's not enough. I've given the high dose with my study, and that was okay to bring them up, but it wasn't enough to maintain them. And I think that going forward, we need to do some dose finding studies looking at what is the right dose and what is the right interval. And also, why is it so hard to replace a sickle cell patient with vitamin D compared to a non-sickle cell patient with vitamin D? Do they have issues with renal loss? Do they have issues with absorption? All those things have to be researched and figured out before we can say this is the recommended dose for sickle cell disease. But to be safe, you just go with what the Academy of Pediatrics has said a child should get, which is about 1,000 units a day, or about what the Institute of Medicine has said, which is about 800 units a day. And then if you're deficient, you have to talk to your doctor and then kind of work out a plan to treat and follow the levels accordingly. There is no standard treatment for vitamin D deficiency in sickle cell disease. Yeah.
Wonderful, thank you. So it looks like we have one more question, and this is from Jeff. And he says, I understand this webinar presentation is mostly geared toward pediatrics, but are there any current suggestions for adult patients in terms of nutritional/vitamin deficiencies in this regard?
And so I apologize right off the bat because I'm a pediatric hematologist, and everybody's a kid to me, even if you're 25 years old. But this data is applicable to adults as well. The study from Boston was done in adults, where they were all found to be deficient, and their levels came up, but they didn't come up to the normal range after 1 year of being on supplementation. And so we in our adult program here in Atlanta, we do look at vitamin D levels and try to correct their levels over time. The same deficiency you see in pediatrics will probably be worse in adults. If you've been vitamin D deficient as a child, when you become 30, you're going to have even lower levels. So I think the same information is applicable to both adults and children. The same need for more calories, more protein, a different proportion of nutrients, different vitamins, the same requirements as when you get older. You have to factor into the adult situation renal disease. So if you have renal problems, you're going to have to modify your intake a little bit based on your renal status, but definitely it applies to adult sickle cell disease.
Wonderful. Thank you so much. So that looks like all of the questions that our audience has asked. Oh, one more. I'm sorry. This is from Elizabeth again, and it says, does your multivitamin contain iron? I don't know which multivitamin that's referring to. Maybe is Elizabeth on the phone? Do you want to clarify for us?
I'm sorry, what was your question? I didn't hear all of it.
The question, I think, that was posed says, does your multivitamin contain iron? But I'm not sure which multivitamin you're referring to.
Well, she had mentioned that she tells all her patients to, or tells her parents to start their children on a multivitamin, and I wondered if it contained iron or not.
So I tell them to get a multivitamin that doesn't have iron. It's very hard to find. Usually you have to go to like a store brand, Walmart or Target brand to find one that doesn't have iron. However, I've treated some of my patients for iron deficiency anemia. I'll check their iron levels is low. I give them iron until I get them to where they need to be, and then I stop it. But overall, I say a multivitamin without iron, yes.
Thank you.
Okay.
Great. Thank you so much. So we have about 4 minutes left. Does anybody have any question that they just want to unmute their phone and ask quickly before we go for the day? All right. Well, then, I just want to say thank you so much. This was a wonderful presentation. I think there's some great discussion. So there's lots of interest. And I wanted to let everyone know that our next webinar, we're skipping June, but it's going to be held on Thursday, July 28th. And the topic is transfusion issues for sickle cell disease and thalassemia patients. And I also wanted to remind everyone that first 2 presentations have been archived, and those are available. The presentation from today will be archived in the next couple of weeks, and once it is, a link is going to be sent out to the listserv. So thank you all so much for participating, and if you have any questions, you can feel free to contact us at CDC. Thank you.
Thank you.
Thank you.